Right, thank you so much for joining us here on K24 this week. Time to have our conversation and trying to make sense of exactly some of the important issues happening here in the country as far as health is concerned. This particular evening, of course, you're speaking to Mr. David Makumi, who is the CEO of Faraja Cancer Center, and of course, Dr. Stephanie from HCG Cancer Center. I got that right?
Yes.
Oh, good. Now, our conversation today is focusing on demystifying modern treatment when it comes to matters cancer. It has been a subject of conversation in the country for quite a while, and we just want to try and make sense of some of the things that are a subject of concern here in the country. I want to bring to start with you, Stephanie. Most of the time, the diagnosis when somebody is told you has been diagnosed with cancer, it always looks scary. Is that still the case years later? Do we still have patients who look at it as a death sentence?
Okay, so thank you very much for having us on the show. And what I'd say is, over the years, cancer has long been considered as a death sentence to many, which is a myth that we are still trying to tackle, even in this day and age. And of late, we've had many advancements in the treatment of cancer. And this is not necessarily the case, that when someone is diagnosed with cancer, it means that they're going to face death and they're going to succumb to it. So it's still the case, but with the recent modalities in cancer treatments, it has definitely been one of the issues that are being solved.
Okay.
So, yeah.
David, in terms of changing perception, especially with the patients, how has that journey been over the years?
Yeah, I think we've made progress in terms of communication around cancer. We are not there yet. Cancer does instill real fear in families, in individuals, in communities. And those fears are also not unfolded because cancer is expensive to treat. And obviously, when it happens to an individual, it's the individual. It is not the 44,000 new cancer cases that are reported in this country every year. Those are, when you narrow it down to the individual, you know, there is a fear about finances, a fear, as Dr. here is talking about their mortality, fear about the whole long journey. But in terms of now changing perceptions, the help we have had is actually from people with lived experience, people who have survived cancer and are able to come out and say, look, I've been treated for cancer, you know, maybe 10, 15, 20 years. We have very long-term survivors in this country. In as much as we lose nearly 60% of the patients, we have many people who have survived cancer for many, many years. And those are the ones who are best placed to tell the story. We have many brave survivors who are coming out in the public domain, in their churches, in their mosques, in their communities, just saying they went through cancer treatment, they went through the whole, you know, chemo, radio, surgery, or whatever else they were treated with, and they survived it to tell the story, to go back to their families, to go back to their jobs, to go back to be productive citizens of this country. So those are helping change the perceptions. As well as the healthcare workers, they can definitely do more in terms of also communicating positive stories about cancer. And I must commend you know, K24 for this sort of opportunity and forum to be able to communicate what we are trying to say. Cancer is not a death sentence. Patients are living longer and longer, surviving cancer, and even dying from other diseases, not necessarily from their cancer. So the media does play a very major role in changing these perceptions, but we also need our leaders and policymakers, politicians, and everybody else who is in a position of authority, even community leaders, to tell this story. Like, look, if a patient, whether he's an adult or a child, is diagnosed with cancer, there is hope. There is hope that there is available treatment in this country, good treatment like they offer at HCG and many other cancer centers, both public and private. that can help people live longer.
All right. Stephanie,
Yes.
when it comes to communicating that particular message, right now somebody comes to you, you do a test, they actually diagnosed and it is positive, and you want to communicate that message. How exactly should that be happening? Consider, looking at the fact that you actually do want to change perception by communicating in a positive manner. So what sort of messaging do you give to both the family and also the patient?
Okay. Thank you for that question. So definitely no one wants to hear that they have cancer.
Yeah.
It's usually a devastating diagnosis. From what we've experienced, even when someone is coming in with their reports, they've been sent for certain tests, certain scans, and they're coming in, and now you have to break the news to them. So what we do, we usually do it step by step. We take them through. We actually take time to explain to them what is happening, and we do it in terms of whatever test they've come with. So for example, we could use, probably someone has just been diagnosed with breast cancer, and you're going to break the news to them. So you look at their certain scans, you look at the CT scan of the chest, the abdomen, the pelvis. You'll also look at the biopsy results. They have to have all these tests. And then now you take them through, you explain to them what breast cancer is and what the various treatments that could be done for them to possibly get a cure from breast cancer, because it's also possible when diagnosed early and when treated radically, it's possible to cure the disease. So we usually give them a range of options, and we also advise them based on what is best for them. And we also look at very many factors. We look at their family status, whether they have a supportive family, whether they even have SHA to afford some of these treatments that we're going to recommend. So it's usually also in conjunction with having a psychologist on board. So for example, you could tell someone that they have breast cancer and the reception is not very positive. Some of them get very devastated. They become sort of numb, or they become
It's a shock.
Yes, it's a huge shock to them. So what I do in such a case, because we also have trained psychologists, we work hand in hand with organizations like Faraja Cancer Support Trust. We just call on board a psychologist once you've given the news and you know that this person may not be okay for a certain period of time until they adjust. We always have a psychologist on board working with them.
Let me understand in terms of the care that you give right now and how it was some time back. Not that you were born then, but just looking at the industry and also the history about what has been done before and what is being done today. What would you say are some of the differences that we've seen in terms of how we handle this kind of communication to the patient?
In terms of how we handle the communication?
Yeah.
Okay. So before, for example, I would use this as just an example. The communication was definitely that if someone gets that diagnosis, the fear was that they're going to die. But now with the recent developments, especially in research with clinical trials, there's a lot of developments that have been made in terms of cancer care. So people are even able to access these treatments within Kenya. They don't have to travel all the way to other countries to access treatments like radiotherapy. Even chemotherapy is available, surgery is also available for these. So when we are communicating with them, it's easier nowadays to tell them, even based on what Mr. Mokomi was alluding to, because of having the higher survival rates nowadays, it's better to even communicate such through the survivors, through cancer survivors, through cancer advocacy organizations, and even through the doctors that we have.
Okay.
Yes.
I'll come to you, Dr. David Mokomi. However, sir, I want to look at what you just mentioned, which is that we don't have to travel abroad, because in most cases, most of the time, and I like to us to demystify that, that most of the time when somebody is diagnosed or is thought to be having cancer, one of the things that we normally look at is, okay, should we now start looking for a ticket to India and things like that? What are some of the cases that will force someone to actually travel outside the country, and what are these cases that we can actually get to manage internally?
Okay, so before people used to travel a lot, and nowadays that has really reduced. Medical tourism, I think through other hospitals, even the ones that I cannot really mention right now, but medical tourism has been a thing for, especially in oncology.
When you say
yes,
medical tourism, what does it mean?
it means you're traveling to seek care abroad.
Oh, okay.
Yes. So in those countries, that's the term medical tourism applies. So in this case, nowadays when, for example, if you need certain tests to diagnose or to even evaluate the staging of the disease, for example, a PET scan, you don't have to travel because that's also available locally. It's available at HCG, Cancer Center, it's available in many other hospitals. And it's something that is also becoming more accessible with time. Even, for example, the targeted therapies, you can have certain cancers where that respond to different targeted therapies. You could also have the radiotherapy. All that is becoming available within the country. So you don't necessarily need to travel. We've had also patients who have traveled and have come back. And the oncologist is also in communication with those, the oncologists who are seeing them abroad. Okay.
So it is dependent on what you've been diagnosed with. That is exactly what is going to identify or rather inform the kind of treatment that you're going to have.
Yes.
When you're speaking, David, you're talking about the cases that we have in the country most of the time. In a year, we record like how many? 44,000, that was you said? So 44,000 cases in a year. Which is the most prevalent one that, you know, out of the 44,000 in a year, we always have the huge percentage of this?
Yeah. Majority of the cancer cases that we see, we have to look at the top 5. Breast cancer is the most commonly diagnosed cancer in women, not only in Kenya but even globally. For some, it accounts for sometimes more than 16 to almost 20% of the cancer cases. So breast cancer is the most diagnosed cancer, and for men there is prostate cancer. There are also gastrointestinal cancers like colon cancer, also very, very common in this country. There are also things like lymphomas. They are also among the, you know, the top 10 cancers that we see. Cervical cancer is a big one in this country. It's still a problem. It is no longer a problem in developed jurisdictions, but in our country, it is still among the top. In fact, it is the leading cause of cancer deaths in women. So those are the common ones in adults population. If you look at the pediatric or the children, because children do get cancer, and you know that children are not small adults. Children are just children. So it is important to ensure that we look at them as that entity. For the children, leukemias or blood cancers are also the common, as they are also in adults. Cancers of the kidney, there is a kidney cancer we call nephroblastoma, or Wilms tumor. That's a big common one. The other common one for in the children are bone cancers, very common, as well as central nervous system cancers like brain cancers. Those are also very common in children. Of course, the others, many other cancers. When you get looking at 44,000 new cancer cases, and among them for children is 3,200 new pediatric cancer cases. So there are many other cancers that are also fairly common, even liver cancers, for example. That's common. Things like ovarian cancers, again, very common. Also, esophageal cancer is a big one, and of course, lung cancers. So all those are the ones that we say are more common in this country. If you took those numbers in perspective, what we are saying is more than 100, just about 80 to 100 people are told they have cancer every single day. By the time you and I go to bed tonight, there will be 80 families, so nearly 100 families who will have been told they have cancer. And that definitely changes, you know, fundamentally changes the dynamics in that family, because of think of many things.
Let me ask, because we normally talk about early detection,
Yeah.
encourage. I've seen cancer campaigns and people being
Right.
encouraged actually to go for for screening,
Yeah,
so
yeah.
that we can detect early. When you say early detection, what does that mean? And does it not scare people? Because to some extent, somebody would be like, okay, if I'm going to look for it every now and then, I want to be screened.
Yeah.
Maybe I will get whatever I'm looking for most of the time. What do you say to that?
You are really safer screening. There are a number of things that we must point out. One, we don't screen for all cancers. That's important. We don't have methods to screen for every single cancer. It's not in this country, it's nowhere in the world where they will screen you for every single cancer. So some people have this myth that you might go to India or God knows where else, they put you in a machine and you come out of the other end and they tell you you have or you don't have. We don't have that sort
It
of
doesn't
thing.
work like that.
Those are myths.
Yeah.
So there are very few cancers that we screen for. Fortunately, the ones that we are able to screen for are also the commonest.
Okay. Also, we screen for the common ones.
We screen for the cancers where there is evidence that screening will save lives. So there are other cancers that we don't have screening modalities. You know, you want to say like you are screening people for brain cancer. We don't have screening modalities for some of those cancers. But the few cancers that we screen for, incidentally also happen to be the commonest, like breast cancer. Breast cancer, you catch it early. You are even going to save not just the life of that patient, but even the breast, because they'll be able to do breast conservation surgery. Prostate cancer is a cancer you can screen for. So cervical cancer is actually wrong for our women to die for a cancer like cervical cancer because it's one of the most screenable cancers. And you know what? It takes nearly 15 years from the time a woman, the changes starts happening in the cervix from a virus we call HPV virus to the time it becomes cancer. So you have a whole like 10, 15 years to catch it by screening. And if you catch it early, the treatment, one, is more effective. Two, it's less expensive. And three, it's less intensive. So the whole thing about also people not wanting to go because in case I find it, in case you find it, something will be done. If you don't, it won't go away. If it is there, then by the time you are showing up, you know, you don't want to go to daktari here and say, akulize na wewe umekuwa wapi na hii uvimbe hiyo miaka mbona hujakuja hospitali. So you need to find it for it to be
treated early. And so that is the importance of early detection. Stephanie, what are signs that we should never ignore, based on what David is saying, some of the common ones that we normally screen for? What are some of the signs that people should never ignore? Okay,
that's a good question. Signs and symptoms usually depend on where, which organ is affected. So if we could use the example of cervical cancer, you could have someone with bleeding, vaginal bleeding, probably even in between their menses. Bleeding after sexual intercourse, that's not a sign to also ignore. Pain in the lower part of the abdomen. Sometimes it can go to the lower back. That's also something that you should not ignore. Some people also have foul-smelling discharge. So those are some of the signs that you could notice.
Okay.
Yes.
Let's talk about the advancement when it comes to matters technology and medicine and the treatment itself. Initially, it was termed as very daunting, and somebody you were out. Sometimes people argue and say, okay, the problem is not even the cancer itself; it is the treatment itself that is too much, chemotherapy and all that.
Yes.
Is it getting any better in how we handle that, or is just?
Yes. So when it comes to cancer treatments, definitely they do have side effects. And these are side effects that have been studied over time. But even with the recent developments, as you mentioned, more drugs are being developed, more targeted therapies are also being developed. So it just depends on the type of treatment modality that someone is getting. But with time, it has been improving. And we also, when it comes to chemotherapy, we also give medication that counter these side effects, so that even as someone is getting their probably 4th cycle or whichever cycle of chemotherapy, they're also covered for these side effects.
Okay.
People usually believe that chemotherapy is even worse than the disease itself, and which is not true.
Okay.
Yes.
We've seen people that have said, I am a survivor, and I've hosted a warrior here. And we've had people that, survive and it comes back. And what normally happens in this particular case?
Okay. Again, recurrence. It just depends on how maybe the case was managed in the first place. So probably someone got their diagnosis back in 2024, breast cancer. And they did the radical treatment, they did everything. But probably 2 years later, you notice that probably they have some symptoms. They go check and they find, unfortunately, that the cancer has recurred and it has unfortunately spread. So it depends also, because there are certain cancers that have also that risk of recurrence. For example, brain cancers, they are, depending on the grade, you could have a grade 4. They are called grade 4 gliomas. So those ones have a higher propensity to also recur.
Right.
So it also depends on how someone was managed, whether they had the appropriate follow-up, which is very important. We emphasize when someone is getting chemotherapy or radio, when they finish, they continue to see their doctor even after the treatment, so that we can catch anything suspicious early enough and deal with it. Yeah.
Also, something else I wanted to ask is how usually does the treatment take? Does it have a stipulated period of time?
Okay. That's also a good question, and it depends also on the site that is being treated. So you could have, for breast cancer, it's very different also from brain cancer. Some, even for prostate cancer, it can go up to 2 years if you're getting the hormonal therapy, if you are getting the surgery. The follow-up is usually over a long period of time. So it just depends on the site that is being treated.
Okay.
Yeah.
David, as we wind up on this conversation, myths that we've been told over the years in regards to cancer and things that we need to demystify until this particular moment, what are some of them that you come across?
Yeah, I think one of the single most important communication piece we need to tell people out there is a myth that, if you touch the cancer, it's going to spread and kill you. And sometimes, people will say, you shouldn't touch that cancer. The one way to diagnose a solid tumor is to do what is called a biopsy. You need to take a small tissue, take it to the lab, and a pathologist will have a look at it and say it is cancer or it is not. So there are people who say, no, you should not even have. I've had people, fairly educated, say they cannot even have a biopsy. There is no way you talk about cancer unless you've had a tissue diagnosis. So people out here will say, it is because it was touched. It is because this patient had surgery. The reason people we have a very high mortality or death rate is because the cancer has been diagnosed early. It's not because the biopsy was taken or surgery was, or surgery was done. It is because that that disease was advanced at the point of diagnosis. So the other myth that I know people may have is, it is cancer is not communicable. It is what we call non-communicable. So you have a patient with cancer in the family. They are not going to. It is not going to jump from one patient to another.
That I can't share a cup with you because you actually have cancer.
So it is not infectious. Two, for patients who are also receiving their treatment, they need to complete their course of treatment. One of the things that our patients are facing out here is this notion that they must go somewhere, eat certain food, go and take certain supplements, go and wawekelewe mikono mitakatifu to some place.
So that is a myth, because you see quite a lot of traditional doctors, traditional herbalists will be out here saying, we have a cure for almost every country.
Just about everything. What we have seen, and we run, for example, at Faraja Cancer Support Trust, we run 10 support groups for different cancers. And the stories you hear of people who have used lots of money, sold their property to go and give to a certain a traditional healer, somebody from some village, big money going down the drain. By the time they are coming back, the disease is advanced. So the things like prayer have their place. And even as we pray very seriously, But we must pray and get people to have their chemotherapy, have their radiotherapy.
Okay.
So if it is reading them out of the mainstream medications that have been prescribed, then there is something fundamentally wrong there.
All right. Stefan, yeah, my last question will be the aspect of hair loss. Does that mean that anybody that is going through chemo or suffers from cancer, then we have to start looking at you know, losing your hair and all that? Because I remember there's a time I met someone and she was, no, they were having a conversation and somebody asked, okay, so I'm not seeing you lose your hair, and yet you, so okay, I haven't, and I don't know. So what happens here?
Okay, so again, it also depends on the type of chemotherapy that someone is getting. Not everyone gets hair loss from chemotherapy. And also one thing is the hair comes back. Yes, after someone has undergone the chemotherapy, with time, the hair grows back. So chemotherapy, there are certain types that affect the cells that produce that are responsible for hair growth. So that's why you can tend to have the alopecia.
So it is not all of them that
not
actually
all of
will
them.
lead to hair loss?
No, they don't. Yeah.
David Makumi, CEO of Faraja Cancer Center, thank you so much for your time. And of course, Dr. Stephanie, clinical oncologist from the HCG Cancer Center in Parklands. Much appreciated for your time.
Thank you so much.
All right, that does it for us here on K24 this week. I hope you're well informed now. My name is Brian Amwa. You do have yourselves a lovely time.
Thank you.